Well, ladies and gentlemen, the rotator cuff is a series of tendon which joins at the humeral head, and unfortunately, although I have here no conflicts of interest with this talk, and unfortunately it may fail. Now, we have the vision that it is a wear and tear and degenerative phenomenon. However, there are a few interesting questions. Why does he not have a rotator cuff tear? He uses his arm quite a bit. Why are supraspinatus tears as frequent in dominant and in non-dominant limbs? Why are supraspinatus tears not more frequent in manual than in office workers? And actually, quite interesting, why do we either have a rotator cuff tear or osteoarthritis? At least if we look at the images, we see that rotator cuff tears and osteoarthritis show very different images. So we have a rotator cuff tear and osteoarthritis which look different. If we measure the geometry of the cuff, then we see that something like the critical shoulder angle or the inclination of the glenoid fossa and the length of the acromion are very different. Interestingly, with large rotator cuff or with rotator cuff tears, the angle is very big. Actually, with osteoarthritis, it's very small, and very interestingly, in normal shoulders, it is exactly 33 degrees with also a very small standard deviation. So the facts are clear, but do we understand that? Yes, actually, it is quite an interesting phenomenon. The deltoid is an antagonist to the supraspinatus tendon if you have a very large acromion and it pulls the head upward and increases the load on the supraspinatus. If you elevate your arm and you have a very short acromion, then the deltoid becomes an agonist and compresses the humeral head against the glenoid. Now, if we measure that on a simulator, we can try to quantify this phenomenon. We have done that, and we have shown that the supraspinatus load to stabilize the arm in space is an additional 33% if you have a critical shoulder angle of 38 degrees rather than 33 degrees. So overall, to hold the arm in space, you increase the load on the supraspinatus by about 30% with a very minimal lengthening of the acromion. Now, this is 2.3 to 3 kilograms. However, as you see here, the subscapularis, the infraspinatus and supraspinatus are very large muscles. And if you know that per square centimeter you generate about 4 kilograms of force, you know that will be between 20. And if then you add another 5 kilograms to your supraspinatus, this may really lead to failure. If we look at the intra-operatively generated active supraspinatus tension versus the Goutelier stages, then you see that if you have a Goutelier stage of 0, the force of the supraspinatus or of abduction is about 20 kilograms, and if it goes down to stage 2 or 3, the force is much lower. So actually you would expect that with the supraspinatus creating about 166 Newton, but the infraspinatus creating about 395 Newtons, that you're in problems, because we know that for the open repair with Ethibond, you get to a tension failure of about 329 Newtons. Arthroscopic repairs are even lower. And if you look at Goutelier stage 2, then you're still at the very, very high level of failure. You're at the level of the failure that you can induce with the sutures. Nonetheless, you know that the failures occur in the Goutelier 2 and 3 and 4 stages, although the force that the muscle can generate is lower. Why is that? This is because these muscles lose elasticity, and we have measured in man that the increase of the inelasticity is about 2 to 3-fold, and experimentally this is even much more. Now, if we look at the Goutelier stages, you can say the Goutelier stages are correlated with the tear size. The larger the tear size, the higher the Goutelier grade. Interestingly, however, the tendon length also decreases. And we have looked at the tendon length in a variety of papers. And you see here the tendon length measured on MRI, for which we developed a specific MRI technology. If the tendon is longer than 15 millimeters, then you have a 25% failure rate at Goutallier 0 and 1. However, if the tendon is short, then you have a much, much higher failure rate. Actually, if you have a Goutallier stage 2 and 3, but a long tendon, your failure rate is lower than if you have a Goutallier 0 and 1 with a short tendon. So tendon length is a very important factor. Myotendinous reduction in advanced stages is also due to tendon shortening. The residual tendon stump after tendon tear does not have the original tendon length. And if you want to repair anatomically, you have to lengthen the supraspinatus muscle beyond its original length. That means that it is probably a lot smarter to medialize the tendon from its original insertion than to use something like a double row so that you have to pull it out even more. And we know that medialization up to 1 centimeter does not induce any real problems with the range of motion, whether this be in abduction, in elevation, or rotation. The reasons may be what they are, but the failure rate of repair is 30 to 90%. And the reasons were the things that have followed throughout my career, and I think it was the goal to understand the enemies to healing. And these are the reasons why it cannot heal. And the first one is the suture. We studied the capacity and the properties of the suture. And you see here that if you use very stiff sutures, you do not get gapping, as opposed to PDS, where you get at 200 to 200 Newton, very substantial gapping. We then started to look at tendon grasping techniques. And the tendon grasping techniques were all assessed with such systems here in sheep tendon. This here is a simple stitch, this here is a U-stitch, and you see that at the load of about 10 kilograms or 15 kilograms, these sutures fail. Remember that the tension, the spontaneous tension of the supraspinatus is beyond 20 kilograms. So all these sutures fail if you have an involuntary contraction, except for the Kessler and the Mason-Allen sutures. We also looked at where you can put the stitches so that they hold, and the holding power of the stitches is very different from in human supraspinatus tendons, and the positions 5 and 6 anteriorly behind the rotator cable are actually the two positions which are really very critical if you want to repair a tendon and have a holding power that is sufficient. The fixation to bone was the next parameter that we studied, and we saw that about 18 kilograms the sutures pull through a human humerus and do not hold. So either you use a cortical augmentation device or you use anchors if you were able to put the anchors in the right place. Here we studied the bone quality, and the bone quality showed in chronic tendon tears that the greater tuberosity is essentially empty. We looked at the resorbable anchors and could document that if they were tested at body temperature, it took between minutes and 1 day until the sutures had cut through these anchors and really were of no value after about 24 hours with loading in saline. Here you see we looked at how you have to tie the knots. I mean, all of you know how to tie knots. The only thing is I did not know. I did not know that I really need 7 knots until a suture knot is stable. If you have less than 7 knots with all the fiber wires or so, the knots will not heal. You need 7 knots until your suture breaks rather than dissolution of the knot. We looked at the neurovascular limits and could show that you cannot lateralize the muscle by more than 1 centimeter without causing injury. So if you have a substance destruction of more than 1 centimeters, you cannot go laterally without injuring the neurovascular junction. But knowing all that, we still had a failure rate in massive tears of 34%. And we found that the reason for that was the quality of the musculotendinous tissue. So we needed a model for fatty infiltration and created the model with this sheep infraspinatus repair. This here are the sheep who are examined under CT. That's what it looks like. Then you have the two sheep shoulders, which show the infraspinatus. Below is the normal infraspinatus, and above is the fatty infiltration with the osteostomized chip, which is medialized. When we did that experiment, we saw that the contralateral side does not react, as opposed to the osteotomized side, where you get very rapidly fatty infiltration within 6 weeks, and this fatty infiltration at 40 weeks, when you repair, is increased. So we could document that if you repair a retracted tendon, you do additional damage, and you do not ever come back to a better situation than at the time of repair, as far as fatty infiltration is concerned. Macroscopically, it was so that the pennation angle changes dramatically, as you see above, which is associated with a dramatic shortening of the muscle fibers. Now, this shortening of the muscle fibers is a major problem, because if you want to go on and want to repair the muscle, then you see that a normal retraction goes this way. So if the muscle contracts above, this is a different phenomenon than from the retraction. The contraction above leads to thickening of the fibers, whereas the retraction, as shown below, will lead to opening between the fibers and increased fatty infiltration. So if you want to lengthen that, you have to lengthen by the distance that has been retracted. And if you look at the muscle fiber length, you see here that you have to lengthen the muscle fibers about 3-fold. And you know that you can lengthen the muscle fiber by about 25 to 30% without tearing it. Thus, single-stage rotator cuff repair will lead to rupture of the muscle fibers. We therefore tried to do that with staged repairs or with continuous traction, and could show that if you use continuous traction, that then you can restore the architecture of the muscle. However, you can also come back and can improve atrophy. You can prevent ultimately a little bit of fatty infiltration. But even with that method, you still have relatively advanced fatty infiltration, which does not go away. So the recovery with continuous traction leads to extension, restoration of architecture, but not to restoration of muscle fiber size. So this, what we're seeing here, is at the moment still a dream. Now, this is an interesting dream because now at least we have a means that we can measure very exactly with Dixon sequences the fatty infiltration quantitatively, as you saw on the last slide. We have then tried to reverse anabolic steroids using traction, and this in sheep. And the interesting thing, the question was, do anabolic steroids or insulin-like growth factor help to treat the fatty infiltration? And the answer is no. Rotator cuff muscles lose the responsiveness to anabolic steroids after tendon tear and musculoscandinous retraction. So the question was, can it be prevented by anabolic steroids? The answer is yes, it can in the rabbit, and to make it short, yes, it can in the sheep. On the right-hand side, you see the graphs with muscle infiltration, fatty muscle infiltration with animals that are treated with anabolic steroids, and this can prevent fatty infiltration. We can show that retraction is associated with downregulation of the receptor for anabolic steroids, and that this can recover. So if applied from the time of tendon release, the anabolic steroids can prevent fatty infiltration, and that may become interesting. They do not prevent atrophy, interestingly, and they do not prevent retraction. If they're applied at the time of repair, they prevent further atrophy, but they do not reverse established fatty infiltration. So the talk's title was My Journey to Get the Cuff to Heal. You see that it is a winding road, has not ended anywhere so far, but has been quite interesting. If I look at what I learned during this way to be practical, I think the first thing that I learned is that it makes sense to assess repairability. If you want to repair, successfully repair, do it in fatty infiltration stages 0 to 2, and with tendon length that are more than 15 millimeters. If you use a repair, use solid sutures, either Mason-Allen stitches or many fixation points, medial to the cable. Absolutely avoid overtensioning. It is certainly better to medialize in the insertion of the rotator cuff tendon, and therefore, for massive large tears, I think double rows should be avoided because they require too much tissue. Protect the repair. I do lateral acromioplasty normalizing a CSA, and you see that here on the right-hand side. Typical rotator cuff repair, you have your lateral acromion on in the video there, and you just burr away the lateral border of the acromion. That can be done very easily, and we could show that deltoid detachment is not observed in more than 50 cases now, controlled with MRI. The deltoid functions well, and if you are careful, you do not detach the deltoid. And if you have done that, repaired, and have corrected the form of your acromion, you have probably unloaded your rotator cuff repair by about 30%. Be careful with little movements. We were very surprised to see that the highest strain on the cuff is between 20 and 60 degrees of abduction and elevation. It's not higher. If you're higher up, it is the deltoid which works. So be very careful if you give talks after a rotator cuff repair, or only use your left hand if your right has been operated on. Use an abduction brace. Why should you use an abduction brace? You know, did you know that the supraspinatus is the only muscle in the body which is at full length in the resting position? Is fully extended in the resting position. So no other muscle is that. So it is at maximal length, and if you look how long it is, and if you use an abduction brace, you dramatically shorten the supraspinatus and you relieve tension. Well, Jim, thank you for inviting me. First time I was here was a medical student in 1977 here in San Diego. I am unhappy that I could not provide you with any technique or implant to really solve the problem, but I was happy to come back, and I'm still trying to understand the enemy to healing. Thank you.